Bonjour à tous.
Good morning, everybody. Good morning and welcome to this prestige lecture. It's my very great pleasure, my very great honor to welcome to the podium Professor Daniel de Becker, who, as you know, works in Brussels as an intensive care doctor. And over the years, he has become a major player in research in our field of activity, particularly when it comes to the vast area of hemodynamics. Daniel is greatly involved in our society. He was Secretary General, in fact, at one point, and he's currently president of the European Society of Intensive Care. Daniel is Belgian. Daniel, we're very proud to have you as a member, and we'll be very pleased to hear you give this prestige lecture, The Treatment of Shock from Heart to Tissue. Good morning. It is a very great pleasure and a great honor for me to give you this lecture. When you talk about shock, the first question is, what is shock? Various experts have defined shock within the European society. It's a acute circulatory failure associated with inadequate oxygen utilization or delivery by these cells. So there isn't sufficient oxygen to meet the demands of the tissue. Hence, there is an insufficient delivery of oxygen to the tissues, which leads to cellular dioxia. One needs to backtrack a bit and go back to the 70s and 80s in order to understand what exactly this relationship is between the delivery and transport of oxygen. Things may remain stable thanks to a compensatory mechanism. However, extraction capabilities sometimes are exceeded, and then unfortunately oxygen consumption drops. This defines a VO2 critical state and a state of critical extraction. EO2 is a marker of circulatory incidence. You can see that levels drop gradually. So it's perhaps not the best marker when it comes to saying we have reached a circulatory failure. In other words, VO2 delivery has not become the critical issue yet. There's lactate, for example, which then goes up when you reach a level of critical DO2. So you can use a thermometer, so to speak, and you can say whether the cells are happy or not. So we can thus use SVO2 to assess the balance between oxygen consumption and delivery. Lactate indicates the balance between O2 demand and O2 consumption. But there are other markers we can also look at. In a lab, it's been shown that the venous arterial PCO2 gradient goes up suddenly, exactly at the same time as this critical DO2. So when you want to assess at the bedside the VO2-DO2 relationship, you can do what we did in the 80s and 90s, but it's very complex. Likewise, it may be error-prone. So we've changed, and more recently, we have three main indicators which enable us to make the diagnosis: SVO2, also lactate, and PV, etc. In various articles and reviews, when we talk about shock management, lactate ranks very high because one can identify patients who will develop circulatory failure and who can benefit from various treatments. Any number of studies, and this one in particular, shows there are 38 patients, and one can see there's a gradual and virtually linear increase in the risk of death when there is an increase in lactate. You have to look at these four parameters. There's an intermediate level of lactate, which shows there's a marked increase in death. It's still time to react. You have to react quite quickly. People say lactate may be due to other things and not just cellular hypoxia. However, when you look at patients in an ICU, here patients with a septic shock, we measured at the same time lactate and lactate pyruvate. And in an acute phase, most elevated levels of lactate are linked to hypoxia. When time goes by, and this is 24 hours later, very few patients still have hypoxia. However, other sources start to take over. If you use lactate, you have to be fully aware of the time when you're looking at the lactate. Early on, this may point to hypoxia. Later on, there may be other factors. And you have to look at the patient hemodynamics in a more general way. There are other factors. CO2 gradient is also quite important. This is one study inter alia which shows that a CO2 gradient over time is an indicator of the prognosis. Here you can see the organ dysfunction and, in other circumstances, patient death. If you look at respiratory failure, if you look at the CO2 gradients and the arteriovenous difference in terms of oxygen, there you can measure at the bedside, and when this gradient is normal, you can see that there will be no modification in consumption. When the gradient is high, however, you can see here that there is an increase in oxygen consumption. What is more interesting is to note that this provides additional information over and above lactate. 135 patients, we measured the gradient in lactate. Patients with normal lactate and a normal gradient have a very good prognosis. Patients with an altered gradient and a high lactate have a poor prognosis, and between the two, there are all sorts of possible combinations in terms of high lactate or lower high gradients. In a paper to be published in a couple of weeks, we summed up the way in which one can look at these gradients. This gradient, when it's normal, it simply means that the perfusion is normal and the metabolism probably too. When the gradient is high, this would suggest an alteration in perfusion. If SVO2 is normal, there's probably altered microcirculation. If CVO2 is altered, there's probably inadequate cardiac output. You need, in addition, to look at the difference between CVA-CO2 divided by DAVO2. This reflects the respiratory quotient. If it's under 1, it's normoxia. There's no cellular hypoxia, but if it's high, there is cellular hypoxia, and it's high time to intervene from a hemodynamic stance. There are different kinds of shock. There are 4 main types of shock, in fact. As you know, you have obstructive shock, hypovolemic shock, cardiogenic, and distributive shock. We're going to look at distributive shock. However, how do you diagnose things? Things have changed radically. Of course, thanks to ultrasound, we have been able to go further in our analyses. The use of ultrasound is the main diagnostic tool when it comes to assessing the kind of shock in this kind of patient. Ultrasound ranks high because you can distinguish between the 4 main types of shock. We're going to look at distributive shock mainly. The other shocks are quite easy to treat. Hemodynamic shock, you have to correct the blood volume. Obstructive shock, pulmonary embolism, tamponade, cardiogenic shock, you can improve cardiac function. But for distributive shock, things are far more complicated. There isn't just one problem. Indeed, the alteration in tissue perfusion may be due to several different factors. For example, a decreased vascular tone, which will alter the distribution of blood in the various organs. There's myocardial depression, which plays an important part. An alteration in regional perfusion. The division of blood amongst the various organs will be altered. An alteration in microvascular perfusion is also very important. When we treat our patients, therefore, we'll have to intervene on all these 4 scores. First point, which was recognized many years ago, an alteration in contractility. This is a reversible phenomenon. You can reverse it quite quickly. Sometimes it looks like myocarditis in some patients. alteration in regional perfusion. Here you have the gradient between venous saturation, hepatic saturation. This increases in sepsis. There's maybe a preferential desaturation in the splanchnic tissues. This was proved by any number of authors who did catheterization in the subhepatic vein. This was done in the 80s and 90s. It would be difficult to do now. What's more interesting than showing that there's this alteration in saturation is the following. Patients with the saturation alteration in the hepatosplanchnic area depend on oxygen transport in a different way from other patients. Here you have an increase in oxygen transport in the splanchnic area, and you can see there's an increase in oxygen consumption. These patients need hemodynamic treatment, which may not be necessary in other cases. One shouldn't forget the intestines. Look at these velocities. The patient, you can see that these look quite good. There's fairly good perfusion. However, in this patient, there's an ileostomy. This patient has an atrophy of the villi, and you can see that the situation is highly altered. This patient has a marked intestinal suffering. This is another study using different techniques. You can see O2 saturation here, which may reach extremely low levels, minus 20%, for example, in certain parts of the intestine in these patients suffering from septic shock. There's another kind of circulation which is altered, and we sometimes neglect cerebral circulation. As you can see in this study, there's a covariance between cerebral perfusion assessed using transcranial Doppler and arterial pressure. You can see that arterial pressure may be quite high. That's disquieting. When we assess the kind of arterial pressure we want to have in our patient, sometimes we may make a mistake and have fairly low levels. So this may go hand in hand with brain hypoperfusion. And finally, there's a unique phenomenon in septic shock, the loss of self-regulation into flow. In normal people, when the cardiac output varies, there's no major change in brain blood flow. With septic shock, with colleagues in the 90s, we have shown that when you give dobutamine, you increase cerebral circulation in these patients. And finally, to finish, one shouldn't neglect microcirculation. This is a picture of microcirculation in a voluntary normal patient. You can see the venules, the capillaries. There's a fairly rich network of vessels with septic shock. The venules are well perfused. Some capillaries, like this one, are well perfused as well. There's a well perfused area here, but just next door, look at these little red blood cells which aren't moving, so this is not perfused for quite a period of time. In figures, we have shown that there is a drop in vascular density. There's a major drop in the proportion of perfused capillaries, which help to exchange oxygen in the microcirculation, even if the total cardiac outflow has been preserved together with blood pressure. There is a heterogeneous microcirculation, which is very important, therefore. And this article appeared in 2002. Any number of authors have shown exactly the same alterations. There's a drop in vascular density, a drop in perfusion of capillaries, and heterogeneity between the different areas. Unfortunately, this is linked to the future of the patient. The more these alterations are severe, the greater the risk of death in these patients. What's more important, perhaps, are the factors which contribute to this poor prognosis. This is a study with a small number of patients, which is very interesting. It shows the drop in the perfused capillary density, which goes hand in hand with a bad prognosis, a drop in perfusion of the capillaries too, an increase in heterogeneity likewise. Conversely, the velocity villi, the speed of red blood cell circulation, is not different in survivors and those who die. When you can try to increase perfusion, cardiac output, but you need also to look at diffusion. You have to recruit vessels. You have to increase the number of red blood cells circulating. What about treatment? What are we going to do? We're going to look at the factors associated to a poor prognosis. Hypotension is indicative of poor prognosis, like wise cardiac dysfunction, SO2 at bad levels, and a high central venous level. So if you correct severe hypertension, does that improve tissue perfusion? We don't have a lot of data in humans. The only reliable data come from Claude Martin, who a couple of years ago showed that if you correct severe hypertension, you can improve the diuresis and also creatinine clearance. Other data confirms this. It's very difficult, however, to do reliable measurements if the patient has low blood pressure. It's hard to obtain reliable measurements. What blood pressure should one target? Several studies have been carried out. Pierre Asfar, for example, and other colleagues who are probably in the room have shown that there's no major difference in terms of future when it comes to low pressure and slightly higher pressure. Some subgroups of patients can benefit, but unfortunately there are other side effects. Therefore, unfortunately, one cannot systematically propose higher pressure. Jacques Duranteau and his team proposed a renal Doppler. Some patients like this one probably need higher blood pressure, whereas this patient probably should have a slightly lower pressure. There's another aspect which we worked on, preload optimization. I'm not going to go into the details. I'd just like to sum up and say that it's an open issue. Should one give a lot of fluid, a small amount of fluid? What parameters should one use to decide whether patients need more or less fluids? Clearly, according to our data bank, there's an area here where you need to supply fluid. If you give too much fluid, the prognosis is bad. If you give too little, the prognosis is bad too. So for an ICU doctor, you need to find the right balance. To this end, in a study we carried out, we saw that sometimes we don't take account of our errors. We give fluid, this doesn't work, there's no hemodynamic effect. Yet, as you can see here, when patients have a negative response to the filling test, we don't stop. We continue to supply fluid, whereas it's been proved that this doesn't work. So try and think. When something doesn't work, there's no purpose to be obstinate. You need to find an alternative. The alternative can be inotropic support. Here, we need to decide which patients will truly benefit. Look at cardiac dysfunction. There's an alteration in the ejection fraction, but that's not sufficient. You can see here that some patients like this one with an ejection fraction alteration should not get dobutamine or another inotropic treatment. Without for example, ultrasound, without this altered ejection fraction, you can see that there's a low cardiac output, but here again, there's no point in providing this further treatment. Ultrasound enables us to detect patients with a low cardiac output linked to an alteration in contractility, and they might benefit from inotropic treatment. Dobutamine was initially proposed. It's probably an excellent choice, even if there are certain limits, as we all acknowledge. Levosimendan seems promising, at least in experimental studies in human beings. We need further studies. We have just this one, which showed in a tiny group of patients that some patients don't respond to dobutamine, and they might therefore respond to this other substance. Vasopressor support, that's open to discussion. There's several receptors that can be stimulated in order to enhance contractility. One can also block certain agents which leads to excessive vasodilation. This is what we mainly use. Sometimes, however, we forget the beta effect. We don't always calibrate the beta effect. I'd like to say the more you have beta, the better you have a cardiac output, yet you may have an excessive response. In terms of cardiac output, With a given agent, you may get a better output than with others, but one shouldn't focus only on cardiac output. When you look, for example, at splanchnic circulation, you can see that although the cardiac output is higher, there's hypoperfusion of the splanchnic area. So you have to look at the metabolic dimension. One has to realize that this will depend on the dose, and if the perfusion effect seems to be stationary, when you strongly increase the dose, then the metabolic effect becomes exponential. It goes up very quickly. There will be a marked increase in lactate, whereas you have exactly the same blood pressure and cardiac output. This was shown time and again. In a bigger study, you can see that there's an increase here, which lasted for several days. Yet there's a greater tachycardia, which may not be a very desirable effect. Dopamine was one of the substances widely used, perhaps rightly or wrongly. We don't really know. We used it without really knowing. We thought it might have beneficial effects. Whenever we studied the beneficial effects, we realized that the study didn't truly highlight these effects. If you look at these other studies, you can see that there is a problem. The use of dopamine, compared with other vasodepressors, seems to go hand in hand with an increase in mortality. We conducted a multi-center randomized study. We compared dopamine and norepinephrine in the treatment of shock in 1,679 patients. We observed that there was no significant difference between the two. Mortality is perhaps a little higher in the dopamine group compared with norepinephrine. There's no advantage for dopamine in terms of survival. If you look at subgroups, it's striking to see that the patients who react most in terms of the heart and those with cardiogenic shock suffer from excess mortality when given dopamine. It's better to give them norepinephrine, contrary to the guidelines at the time. In patients with a septic shock, there was a trend, but nothing more than that. If you look at side effects, you can clearly see that arrhythmia is more frequent in patients treated with dopamine. So one can wonder whether it's good in terms of side effects. Other studies have appeared with a similar design, and they showed a similar trend and exactly the same problem of more arrhythmias. Logically, when you do a meta-analysis, you can see that there's excess mortality in patients with septic shock that get dopamine, so it's better to use norepinephrine in these patients. One should perhaps use non-adrenergic agents, so you can use vasopressin, for example. We're a bit perplexed. We have the VAST study. It's a big study which compared vasopressin and norepinephrine. There's a slight trend, but it's not really significant. A subgroup seemed to show an improvement, but we need more definitive data. Then the Banner study was presented in Berlin. It showed no advantage or drawback in terms of vasopressin. So we're not fully satisfied. There's probably a subpopulation that can benefit, but we'll have to go into this in greater detail. Other substances like NO are not really very useful. Now, I would like to talk about something that we don't really often do at the bedside. We can wonder how to resuscitate or revive microcirculation. We tend to focus on systemic hemodynamics, but one of the problems, as I said at the outset, was even if organs get enough blood, within the organ the distribution of blood is altered, and the cells may be hypoperfused, even if overall perfusion seems okay. This is a very important paradigm because we're not going to talk about correction, but about or convection, but about diffusion. Do our treatments recruit microcirculation? Let's look, for example, at the effect of fluid perfusion in this kind of patient. Here, once again, we looked at the effect of fluid perfusion on sublingual microcirculation. What we noted is quite interesting. Globally, there's an increase in microcirculation perfusion under the tongue. There's an increase here in these patients, but this was only at the early phases. within 24 hours. 9/10 of patients benefited, but later, after 48 hours, you cannot see any further effect. So the effect seems to be limited as time goes by. There's another point which is very important. Here you have a publication by Potasher which shows that the effect may lead to saturation. You give initial fluids, there's an improvement in microcirculation. If you give a second amount of fluid here, there's no significant change in microcirculation, even if the heart output improves the cardiac output. So there's a minimum amount to reopen microcirculation, which is required, but then it's not fluids that will create an effect. You have to find alternative treatment. However, one shouldn't refrain from using fluids. When microcirculation improves, thanks to fluid perfusion, the next day there is an improvement in the organ dysfunction score. So it's a very good indicator of effective treatment. When there is no improvement in microcirculation, however, there's no improvement in organ dysfunction the next day. Perhaps RBC transfusion might have an effect, but here again, the effect is minuscule, if not nil. But in the individual patient, things may vary. Patients with a normal microcirculation appear to benefit, but the corollary is that when microcirculation is almost normal here, that's one thing, but you should only give this to patients with a marked alteration in microcirculation, as you can see. Vasoactive substances often have a fairly favorable effect, like dobutamine. In humans, you get an effect, but it varies largely depending on the patient. You can't predict this effect. However, fortunately, this goes hand in hand to modifications in lactate. If you give dobutamine, you see a change in lactate, it probably means that it's good treatment. If there's no change in lactate, there's no point continuing to give dobutamine. Vasopressor agents are used to correct blood pressure. You have to be careful. There may be a vasoconstriction in the microcirculation. If you look at normotensive sepsis, you can see this harmful effect of vasopressors. However, when you want to correct severe hypotension, like in this experimental study here, you can see that there's an improvement in microcirculation using vasopressin or norepinephrine. And to finish, I'd like to talk about the impact of vasodilators. When you locally apply a vasodilator, there's an improvement in microcirculation. When you give nitroglycerin systemically, there's a certain improvement, but this is a group of only 8 patients. You have to give a lot of fluids. In a bigger randomized study, you don't see much of an effect, so one can wonder whether this is the right substance, particularly considering it's not very selective. So perhaps one should seek to modulate endothelial function. One of the keys, perhaps, is to look at eNOS. In a normal situation, with oxygen and LR, look at this production of NO, which is a vasodilator. Here, there's an uncoupled eNOS. Even if arginine is there present together with oxygen, this enzyme won't make NO, but it'll produce a lot of free radicals, and certain may be toxic for endothelial circulation in the surrounding tissues. So if you restore the coupling, you can perhaps improve the situation. We tested this hypothesis in a lab. We gave tetrahydrobiopterin, and we showed that we strongly improved microcirculation in these animals. We reduce the heterogeneity in microcirculation. Microcirculation becomes more homogeneous, and this leads to improved organ function and a better outcome. Of course, one should go further. You need to do studies in humans. There may be long-term effects that shouldn't be neglected. So this is a very promising pathway for the future. To wind up, when you talk about resuscitating patients in a state of shock, you have to realize there are different phases in resuscitation. First of all, you do what you can. You try to keep blood pressure up as best you can. And then the next phase, it's very important for us. You have to optimize the patient. You try to optimize tissue perfusion. Let's not forget that once the acute phase is over, we have to work towards a stabilization phase and then de-escalation. We try to minimize complications and wean from catecholamines and achieve a negative fluid balance. I think as time has gone by, we've greatly improved the treatment of patients in a state of shock. A lot remains to be done, however. Despite everything, research at the bedside remains very important in order to improve our general treatment. Thank you very much for your attention.